All right, so as usual, if you have any questions, feel free to pop up and ask them. Feel free to type anything in the chat. I'm happy to have a discussion if applicable. So today we'll sort of talk about, the approach to thyroid nodules from sort of beginning to end, from cytology to histology to molecular correlates. This is a field that I'm very interested in, and I think is sort of burgeoning in the molecular area, which is, I think the way of the future, personalized medicine, refining diagnostics, refining treatment. So hopefully it will be interesting to you guys. So we'll review the workup of thyroid nodules. We will briefly review the cytologic features of thyroid FNA, as well as the corresponding histologic diagnoses. We will identify commercially available molecular tests for thyroid FNA and understand how they're used in guiding surgical management. There are a number of other videos I have online on a YouTube channel in case you're interested in reviewing. The links are there. So to refresh our memory of thyroid development, so follicular cells develop as a condensation of endoderm at the base of tongue from the foramen cecum. They migrate down the anterior midline of the neck via the thyroglossal duct. They then sort of solidify and divide into the right and left lobes, of course, connected by the isthmus across the trachea. If the thyroglossal duct doesn't regress, it may persist and dilate, and of course leave a thyroglossal duct cyst. And if there are little bits of thyroid tissue that don't fully descend, you can sometimes have this midline pyramidal lobe, and you can have ectopic thyroid anywhere in the path of this descent in the anterior midline. The C cells, on the other hand, were originally thought to develop from migratory neural crest. However, it was recently shown that they actually developed from the pharyngeal pouch system, the so-called ultimobranchial body, the last body to develop of the branchial pharyngeal system. These cells fuse with the thyroid gland. So the C cells and these squamoid ultimobranchial body cells merge together into the thyroid and disseminate mostly in the upper to mid poles. So any C cell hyperplasia or medullary carcinomas are actually going to be mostly located in the upper poles of the thyroid, because that's where these structures mentally reside. All right, so here's what they look like. So normal thyroid follicular cells on the left and C cells, on the right. So follicular cells form, follicles are these sort of balloons. When you cut the balloons in cross section, they look like kind of circles or ovals. The follicular epithelial cells lining those balloons are very kind of small cuboidal cells with small, round, very dark nuclei with sort of stippled chromatin, but you can see very homogeneous, right? Very, very round nuclei. On the right are the C cells. Normally, these are not visible on light microscopy unless they're hyperplastic. So this is actually an example of C cell hyperplasia. You can see they form more solid nests and clusters. They have granular kind of purple cytoplasm, but again, very round, kind of regular nuclei. Okay, so just a very brief overview of thyroid tumors, so we sort of know where we're going in this lecture. So tumors of follicular cells and tumors of C cells. So tumors of follicular cells can be separated into well-differentiated neoplasms, like follicular neoplasms, i.e. follicular adenomas and follicular carcinomas, or papillary carcinomas. There is no equivalent sort of benign counterpart of PTC. It's always just PTC, whereas follicular adenomas can be either benign or malignant. If they're malignant, they're of course follicular carcinomas. All right, both follicular carcinomas and papillary carcinomas, i.e. the well-differentiated neoplasms, can transform into poorly differentiated thyroid carcinoma. And all three of those can de-differentiate into so-called anaplastic or undifferentiated thyroid carcinoma, which have increasingly worse behaviors, right? So well-differentiated neoplasms tend to do biologically well, poorly differentiated, relatively worse, and anaplastic, very, very, very poor prognosis for the patient. On the other hand, C cells basically may develop into either C cell hyperplasia, which could be pathologic neoplastic, if in a person who has an MEN type of syndrome, which leads to the development of medullary thyroid carcinoma, or C-cell hyperplasia can be essentially physiologic in response to altered calcium levels in the blood. So C-cell hyperplasia does not necessarily lead to medullary carcinoma, but it can in the proper context. Mutationally, these have usually a different mutational profile. So follicular neoplasms, all of them, can have things like RAS mutations, BRAF non-V600E mutations, PAX8 PPAR gamma fusions. On the other hand, papillary carcinomas tend to have specifically the BRAF V600E mutation. This is the same one we see, for example, in melanoma. They have RET PTC fusions. They have NTRK rearrangements and other BRAF gene rearrangements, or F. The F here means fusion. Poorly diff and undiff tend to have things like TP53 or TERT promoter mutations on top of whatever underlying mutation they may have had in their well-differentiated state. But the acquisition of these secondary mutations generally means worse prognosis. And then medullary thyroid carcinoma is on the RET mutational spectrum. So pretty simple for medullary. All right, so that's our overview of the sort of concept and genetics. So what happens when a patient has a thyroid nodule? So most studies estimate that over 50% of the population has thyroid nodules, either benign or malignant. These are identified either by palpation, visualization by patient themselves, by palpation by doctor on physical exam, certainly by neck imaging performed for other reasons, whether it be other ultrasounds of the neck, CTs or MRIs of the head and neck. Often these thyroid nodules pop up, and now after they are viewed, we are required to sort of pursue them, or at least evaluate them for their potential to be benign or malignant. And so as you can see here, quite a large unilateral swelling in this patient's neck. And here the lesion on ultrasound. You guys are, of course, more equipped to talk to me about the imaging. So here we go. So the first step in the workup of the thyroid nodule certainly is that ultrasonographic examination, followed in most cases, or in many cases, by fine needle aspiration biopsy. FNA is the standard of care, not core biopsy. We do see some core biopsies from some institutions in the community, but this is not great for preservation of thyroid tissue specifically. We prefer the FNA to be directed by ultrasound because it can certainly target the nodule of interest. As we know, many patients have multiple nodules. The neck is a small area. And so palpation can be used in certain circumstances, but for an intrathyroidal lesion, ultrasonographic guidance is preferred for its directedness. And then once these cells, in either case, are aspirated into the needle, through back pressure into the tip of the needle via a syringe, they're then, sort of squirted onto a slide, smeared. And this is on the bottom right, what a smear looks like with those intact thyroid cells. Depending on what the ultrasonographic features are, the patient may or may not require biopsy. So the American Thyroid Association has these index criteria for stratification of nodules into ultrasonographic risk groups, ranging from very high likelihood of being benign, less than 1% malignancy, all the way to very high suspicion of malignancy, right? So very well-defined hypoechoic, to some kind of internal signal characteristics, to solid, to something that's very calcified, stippled calcifications, or even frankly infiltrative. So depending on where a patient lies on this spectrum, they may be directed for FNA biopsy. So based on the ultrasonographic suspicion pattern, as well as the size of the nodule, the larger the nodule gets, the more likely it is to be biopsied. Small, less than 1 centimeter, low suspicion may just require clinical observation, and so on. So once the decision is made to perform an FNA, then the cytologic features on that FNA smear help determine the ultimate need for surgery, right? So FNA cytology of thyroid is a screening test where most can be placed into a benign category and don't require surgery. Some are so-called indeterminate, where surgery may be needed for diagnostic lobectomy. And then some are frankly malignant, in which surgery will generally then follow. Bethesda is the name of the system that stratifies the thyroid cytopathology because it was created in Bethesda, Maryland. Fine. So after the patient then is determined that they may or may not need resection based on the cytology, that is then the final diagnosis from the surgical resection specimen of the patient. So essentially on that screening FNA, the goal is to differentiate benign from malignant to guide therapy. So if the patient's got a cytologically benign nodule and is asymptomatic, they can certainly just undergo clinical observation. However, if it is symptomatic, they may undergo resection just for symptomatic relief. Certainly, if it's malignant, they will undergo resection, but not all FNAs, as I kind of mentioned before, are obviously benign or obviously malignant, and that is that indeterminate cytologic group. So those groups are the Bethesda system ranging from 1 to 6. So 1 being unsatisfactory, like don't know, basically need rebiopsy. 2 is frankly benign. 3 and 4 are the indeterminate categories. So if you read text in the cytology reports, atypia of undetermined significance, follicular lesion of undetermined significance, follicular neoplasm or suspicious for follicular neoplasm, these are the so-called cytologically indeterminate categories that may require repeat biopsy, that may require molecular testing, or that may require diagnostic lobectomy. When it's suspicious for malignancy or malignant, these tend to have very, very high rates of malignancy on surgical resection. So generally these go straight to surgery. Okay, so again, just as a recap of what the outcomes are for these patients, I've listed at the U of C what our internal rates of malignancy on resection are for the following categories. You can see that it ranges from very low 2%, 2% of the cases called benign on cytology end up being malignant on resection, and over 99% of the cases called malignant on cytology end up being malignant on resection. So it's never, 100%, but quite good. So in the end, a patient may either undergo a lobectomy / hemithyroidectomy or a total thyroidectomy. A lobe is going to be for definitive diagnosis of those indeterminate nodules or just low risk small cancers that don't need radioactive iodine treatment. Therefore, they don't need to resect the entire thyroid. Total thyroidectomies are done certainly for non-neoplastic diseases that require symptomatic relief, like Graves or Hashimoto's that involve the entire thyroid gland, right? Or treatment of higher risk carcinomas that will need radioactive iodine ablation. Therefore, the entire gland will need to be removed. Okay, so we're going to go through now some cytohistocorrelation cases ranging from benign to indeterminate to malignant. So in the first case, we have these sheets of bland follicular cells. Some might call them a honeycomb-like pattern with abundant colloid, which is this watery stuff in the background, and scant follicular cells here. So this is in fact a benign colloid nodule. What this looks like on histology is essentially a very well circumscribed nodule. It may or may not have a true capsule. In this case, it does not have a true capsule, but the follicles are large, right? So-called macro follicles, and they are full of colloid, which is essentially why you saw these flat sheets of follicular cells, which is the wall of the follicle, and this abundant watery colloid on the right, recapitulating these large follicles histologically. So this would be a macrofollicular adenomatous nodule, or sometimes called a colloid nodule by some pathologists. But the terminology can be different, but the bottom line is benign. So why do I call these adenomatous nodules? Because we are not able to distinguish based on histology alone whether these nodules are truly clonal neoplasms, i.e. adenomas, or hyperplasias. And so really only genetic analysis, such as the presence of a mutation or clonal X inactivation, will tell you if these are truly adenomas. So I end up just calling them quote unquote adenomatous, because they could be adenomas, they could not be, doesn't really matter. They're benign and they're out. So rather than commit, we just kind of take the path of least resistance here. All right, the next diagnosis on FNA shows these oncocytic cells, which are these more plump cells in clusters. You can hopefully see me highlighting with my pointer here. And then in the background, we have these very small cells without much cytoplasm. Those are the lymphocytes. So we have clusters of oncocytes, background lymphocytes. This is lymphocytic thyroiditis. And sometimes lymphocytic or Hashimoto thyroiditis can be very nodular and can mimic the appearance of neoplastic nodules, whereas these are ultimately just hyperplastic nodules in the background of Hashimoto thyroiditis. So any nodularity in a patient with Hashimoto's on ultrasound might go for biopsy of this nodule. And very often we just see what is essentially a background of chronic thyroiditis with so-called nodular hyperplasia. So we see lots of lymphoid follicles with germinal centers. We see clusters of these oncocytic cells, and these areas are kind of separated by these fibrous bands, which create these multinodular surfaces. So a reminder of what our oncocytes in the thyroid, oncocytes are called Hürthle cells, based off of the man who was thought to have potentially described them. Oncocytes are a histologic appearance of cells that can occur in a number of organs, from thyroid to parathyroid to kidney to salivary gland. What they all have in common is abundant eosinophilic granular cytoplasm, because they are full of mitochondria and these very large round nuclei with prominent nucleoli, because they are metabolically active. So Hürthle cells are the oncocytes of the thyroid, but you can have oncocytes in other organs that are not called Hürthle cells. Okay. Moving on, again, please stop me if you guys have questions. So the next FNA is a paucicellular specimen that maybe shows a few disorganized clusters, rare groups with very wrinkled nuclei, nuclear grooves, and nuclear membrane irregularities, perhaps not a lot of colloid and not a lot of cells. So, based on these nuclear features, these are atypical nuclei. They're not very round, they're not very smooth, they're not very regular, but it's not obvious whether this is maybe a reactive change or truly indicative of carcinoma. So this would be one of these indeterminate nodules called atypia of undetermined significance, which is this reflective of this nuclear atypia. The other indeterminate category we have is more of an architectural atypia, which is also paucicellular, but instead of the nuclei being wrinkled, it's the fact that these follicles are very small and compact. They almost look like rosettes or like microclusters, microfollicles. This is an abnormal architectural pattern for benign thyroid. So again, this is called follicular lesion of undetermined significance, which has this architectural microfollicular atypia. Again, very few cells and not a lot of colloid. On the other hand, once you start seeing lots of cells, very oops, sorry, I muted myself. Very cellular with these sheets of cells, with these microfollicles, even these vessels. You can see these longer kind of spindled cells running through. Those are the kind of unsheathed endothelial cells of the vessels. And again, many more cells clustered around them. This would be a follicular neoplasm or suspicious for follicular neoplasm. Lots of cells, lots of vessels, but the nuclei are still rather round and regular. So the options for this kind of case might be either a very cellular follicular adenoma or even a follicular carcinoma. So these are the so-called indeterminate cytologic diagnoses, AUS, FLUS, and suspicious for follicular neoplasm. Our surgical outcomes of these diagnoses are quite variable. For FLUS, only 7% of these are malignant. Most of them end up being benign adenomas. For AUS, which is predominantly nuclear atypia, those folds and wrinkles, these actually end up being 33% of them malignant, mostly PTC. And suspicious for follicular neoplasm, about a quarter of them end up being malignant, ranging from both a highly cellular papillary carcinoma to follicular carcinoma. So what do these things look like on histology? So this would be a follicular adenoma that likely was diagnosed as either a FLUS or a suspicious for follicular neoplasm on FNA. You can see histologically that it is very well circumscribed. In this case, it does have a thick collagenous capsule, but what you might expect based on looking at the FNA, these follicles are very small or so-called microfollicles, right? They're forming these little rosette-like structures. They do not have a lot of colloid, just tiny, tiny, tiny little colloid in the middle. But the nuclei are very small and bland and round and regular. Grossly, this might be the appearance of a solid white nodule. So this might be called a follicular adenoma or even a so-called the adenoma test is sort of the easy way out. Okay, how do we differentiate this from follicular carcinoma? Well, invasion. So within the nodule themselves, the cells look exactly the same. Small follicles, little colloid, round nuclei, but the only distinction is going to be the presence of capsular or vascular invasion. As you can see, this is why a diagnosis of malignancy cannot be made on cytology for follicular carcinoma, because we don't have the capsule to evaluate. This is a characteristic example of mushroom-shaped capsular invasion, where this tongue is projecting out into the adjacent benign parenchyma, leaving this nodule to be called malignant. The other thing we look for in follicular carcinoma is angioinvasion or vascular invasion. And you can see this plug of tumor out here in this capsular vessel. So this is also diagnostic of malignancy in follicular carcinoma. Here's just a higher power of the tumor cells adhering to the vessel wall, diagnostic of angioinvasion. Okay, moving on to our next lesion, which are going to be on FNA, these clusters of cells, but they have an oncocytic appearance. So how do we tell that they're oncocytic? Again, they have abundant cytoplasm, and they have these very round nuclei with very prominent nucleoli. So this is very characteristic of oncocytic cells on cytology. And so in the absence of lymphocytes, we're probably not dealing with a lymphocytic or an oncocytic thyroiditis, but we may actually be dealing with a Hürthle cell neoplasm. Okay, so remember, Hürthle cells and thyroid can be reactive in the setting of Hashimoto's, or can be neoplastic in the setting of a neoplasm that is predominantly of Hürthle cell type. A Hürthle cell neoplasm can arise in the background of chronic thyroiditis, or it can arise just in a non-inflamed patient. So not specific to the background status of the patient. In this case, this is an oncocytic or Hürthle cell adenoma arising in a completely normal, non-inflamed thyroid, but you can see that it's well circumscribed. You can see it's very cellular. You can see that the cells have these characteristic oncocytic features. It is thought recently that oncocytic neoplasms may be genetically different from non-oncocytic follicular neoplasms, i.e. follicular adenoma and Hürthle cell adenoma may have genetic differences, specifically with the Hürthle cell lesions having mitochondrial DNA mutations, some differences in other chromosomal abnormalities, very low rates of RAS mutations compared to follicular adenomas. So interesting, these are sort of sorting out to be perhaps genetically and biologically slightly different from regular adenomas. Similarly, though, with oncocytic or Hürthle cell carcinomas, just like regular follicular carcinoma, this requires capsular and or vascular invasion. You can again see these tongues projecting through the capsule into the adjacent thyroid. And then in this case, you can see diffuse intrathyroidal invasion. The main dominant nodule is here on the left, and you see these tongues just percolating through the thyroid with lots and lots of background fibrosis. This is intrathyroidal invasion by an oncocytic or Hürthle cell carcinoma. Interestingly, I will point out here, in this particular case, there are these very dark purple areas in the capsule that are calcifications. And sometimes on ultrasonography, I believe you may see these calcs in the capsule, maybe called eggshell calcifications. You can see these types of calcifications in both benign and malignant lesions. It's not diagnostic of malignancy, but it is essentially diagnostic of the presence of a capsule and the presence of capsular calcifications. So it's these cases that we certainly want to evaluate critically, histologically for invasion through the capsule, but some of them end up not having invasion and just being benign. Some of them end up having invasion being malignant. So just a word on those. Okay. Our next diagnosis is going to be a very cellular neoplasm with highly cellular papillary structures. You can sort of see, rather than forming follicles, these form kind of clusters or projections that are essentially papillae. The sheets of cells have dense cytoplasm, have enlarged nuclei that are kind of overlapping. Some are oblong, some are round, some are wrinkled. So this is The stain on this slide is a Diff-Quick type of stain. The stain on the next slide is a Papa-Nicolau type of stain. So there are two different stains that are used in cytology. I'm sorry I didn't mention this earlier, but the different stains highlight different characteristics of the cell. The more of the cytoplasmic characteristics seen here and more of the nuclear characteristics seen here. You can appreciate the nuclei here that have these intranuclear pseudoinclusions, which is essentially nearly diagnostic of course, papillary thyroid carcinoma. We'll talk about the inclusions in a minute. So on low power papillary carcinoma is an infiltrative neoplasm. It's generally composed of both branching papillae as well as some follicles. It has dense fibrosis, which is indicative of infiltration through the thyroid parenchyma. On the bottom left, you see papillae cut either in longitudinal section, as I'm highlighting here, or cut in cross section, as I'm highlighting here. The nuclei diagnostically are enlarged, elongated. They have coffee bean-like grooves. They have overlapping, and they have these characteristic intranuclear cytoplasmic pseudoinclusions. So what are those nuclei, and why do they do that? So it's thought that the nuclear membrane surface area increases, and it starts to fold in on itself, which looks like a groove or a coffee bean. If it sort of pouches deeply into the nucleus, you may see it as an indentation or an invagination. And if it pouches so deeply, and you look at this from the correct tissue plane, it looks like an inclusion, right? So it's sort of an intussusception of the cytoplasm into the nucleus. And if you cut through it, such as here, it is an inclusion. The so-called orphan aniis are essentially chromatin clearing and margination to the periphery of the nucleus, where the center is sort of white or pale and the periphery is blue. This is different from an inclusion in which there is actually cytoplasm in this core. This is just the absence of any nuclear or cytoplasmic material. So just to review a little bit on thyroid cancers, papillary versus follicular. Papillary is certainly the most common, follicular next. So related in some cases to either radiation exposure or iodine deficiency. Very frequently thyroid disease happens in women, but PTC can actually happen in all ages, ranging from very young, even children, to very old. PTC is defined by the papillary type of architecture and the atypical nuclei. FTC is defined by the follicular architecture and that vascular and capsular invasion. As I mentioned before, the genetics of these is somewhat different. So papillary tends to have BRAF V600E mutation. Follicular tends to have RAS mutation. And the genetics of these two types of neoplasms are mutually exclusive. So you're never going to find a BRAF V600E and a RAS in the same nodule. And in fact, these were described by the TCGA, the Cancer Genome Atlas, to have very different genomic profiles in general, not just the single point mutation, but gene expression profiles being very different globally. PTC tends to spread lymphatically to lymph nodes, but generally has a pretty good overall survival, even with lymph node mets. Follicular, once it enters the vessels, so once it has vascular invasion, does spread hematogenously to places like visceral organs, bone, lung, brain, liver. Once it's out and about, survival is a little bit worse. If it only has capsular invasion, survival tends to be quite good. Okay. Moving on to our next type of lesion on FNA. This is a little bit different in the fact that it has these wispy, kind of more spindly or fusiform cells, meaning the nuclei are much more oval and elongated. The cytoplasm is not very dense. The cytoplasm is, again, kind of wispy or pointy, or sometimes even granular. And you may see a chunk or two of amyloid in the background, which is this dark purple kind of cluster. This ends up being medullary thyroid carcinoma. So medullary is papillary and medullary can both be diagnosed on FNA due to their very characteristic architectural, nuclear, and cytoplasmic features. So this is medullary thyroid carcinoma. which is of course our C cell derived and our calcitonin secreting neuroendocrine neoplasm of thyroid. So just as a reminder, papillary and follicular carcinomas tend to not secrete. They don't generally have an excess of thyroid globulin secretion. These, T3, T4, these patients are not in hyperthyroid states from PTC or FTC. However, in medullary carcinoma, these cells are secretory and these patients do end up being in hypercalcitoninemic states. Just bear that in mind. Serologically, medullary should have very high serum calcitonin. Medullary is a low percent, 5 to 10 of thyroid malignancies. Only about a quarter are familial or heritable. Most, 75%, are actually sporadic. So as you can imagine, the sporadic tend to be unifocal and happening in older patients. The familial tend to be multifocal and happening in younger patients. But anyone with a medullary thyroid carcinoma generally undergoes testing of the tumor for RET gene mutation. If the RET gene mutation is present in the tumor, they then generally undergo germline testing for potential germline RET. So basically peripheral blood. Not all of these patients will end up having RET germline, but some will, and you can then pick up a familial syndrome in some of these medullary patients. The characteristic appearance is these nests and cords of cells that recapitulate the C cells we saw earlier with this very, very, very granular cytoplasm and these kind of stippled or so-called salt and pepper neuroendocrine-like nuclei, sort of chunks of dark and chunks of white. The cytoplasm is granular because it contains the secretory granules with calcitonin in them. And the background stroma, buzzword characteristically is amyloid, which stains red on Congo red with this very bright green birefringence under polarized light. So this is a classic example of those features in medullary. Okay, our next diagnosis on cytology are these very solid clusters on the left with very dark nuclei, or on the right, more pleomorphic cells, some of which have a really large nuclei and prominent nucleoli. They don't really fit the patterns of anything we've sort of seen so far. So this is something else. This is some other type of malignancy that might be challenging to diagnose on FNA, but sometimes may end up being either a poorly differentiated or an undifferentiated carcinoma with these very tightly packed solid clusters of cells and poorly differentiated, and these very pleomorphic, sometimes even squamoid cells and anaplastic. These can be challenging to diagnose. Well, poorly differentiated can be challenging to diagnose on FNA, but anaplastic tends to look just very, very pleomorphic and so-called ugly. So if you remember, papillary and or follicular can transform to poorly diff, papillary, follicular, and poorly diff can transform to anaplastic. Poorly diff tends to have survival of a few years to decades. Anaplastic has a survival of on the order of months to sometimes years if a patient is lucky. So you can see increasingly bad prognosis as we transform to more aggressive types of tumors. Here's just a reminder of those genetic mutations that are known to be found in thyroid tumors. The RAS and the non-V600E BRAF, for example, the BRAF K601E in your follicular neoplasms. These genetics tell you that you're dealing with a follicular neoplasm, but they do not distinguish benign from malignant. Once you have something like a BRAF V600E, your RET PTC, or your NTRK BRAF fusions, this is essentially diagnostic of papillary carcinoma. P53 and TERT promoter, as a reminder, you're going to be seeing in the more aggressive types, and RET mutations you're going to be seeing on medullary. So I wanted to remind you of this because finding one of these mutations on preoperative FNA molecular testing will be helpful for determining final treatment surgically in these patients. But unfortunately, not every thyroid tumor has a known mutation. Sometimes we can't really find genetic drivers in these cases, so we keep looking. We're always a continuous search for these genetic drivers. So So how do we deal with these molecular findings if they're found on FNA? So there are 3 major commercial tests for so-called indeterminate cytology. Remember, Bethesda 3, 4, and sometimes 5. Veracyte's Afirma, Interpace's ThyGenX Thyromere, and Pittsburgh's ThyroSeq. In this institution, we send to Interpace, mostly because the reagent is shelf stable and it does not need refrigeration. They can also test off of formalin fixed paraffin embedded tissue like core biopsies, and they provide very detailed genetic mutational analysis. Veracyte and ThyroSeq, the reagent is not shelf stable, so it requires refrigeration, and sometimes the Afirma doesn't result quite as detailed mutational information. Okay, they all kind of have similar answers, however, if you look at them carefully. So all 3 have gene expression profiles, whether they be messenger or microRNA profiles, that sort nodules into those global gene expression patterns that are more commonly seen in benign versus more commonly seen in malignant, right? So again, this is not a single point mutation. This is just global gene expression. Secondly, they all tend to have reporting of those single gene mutations or single gene fusions, like I mentioned before, that are known in thyroid neoplasms, some of them being specific to malignancy, some of them just being specific to a neoplasm, right? So all these 3 tests have both of these types of results. If you have a negative gene expression profile and a negative mutation for any of the tests, you have a very, very low risk of being malignant on final resection, less than 5%. So this basically takes a cytologically indeterminate nodule, right, a Bethesda 3 or 4, and pushes it into a molecularly benign nodule, essentially a Bethesda 2. These patients do not need surgical resection if otherwise not indicated. However, if you have a positive result in any of these categories, it is highly variable and sort of depends on what is identified. So just a positive gene expression profile is different from a, for example, cancer-specific mutation or a neoplasm-specific mutation like RAS. So when you have a positive molecular result, I always recommend really investigating what is reported, because counseling patients and understanding the biology of their disease may very much depend on what specifically is being reported, not just, negative benign or positive suspicious. Really find out what's being reported. So to review, if you have both a negative mutational profile and a negative gene expression profile, this is essentially a molecularly benign nodule. You've taken that cytologically indeterminate, as I said, to an effectively benign neoplasm, or an effectively benign nodule, I should say, where surgery is not definitively indicated anymore. If you have a positive mutation that is implying a follicular neoplasm, right, that being RAS, PAX8, PPAR gamma, non-V600E BRAF, these can be anything from a follicular adenoma to a follicular carcinoma to a so-called NIFT-P, which, if we have time, I will talk about at the end. These patients generally require diagnostic lobectomy, right? So only that lobe for definitive diagnosis between benign and malignant. If you have a positive mutation that's indicative of a carcinoma, right, like a BRAF V600E or a various fusion that's specific for PTC, certainly the patient will undergo thyroidectomy or lobectomy. If you have that RET mutation specific for medullary, again, you got to go for surgery. And if you have an aggressive mutation like P53 or TERT, chances are you're probably also going to undergo surgery, because these tend to sort with more aggressive behaviors in thyroid neoplasms. However, if you have a positive gene expression profile, but a negative mutational profile, it's uncertain what this means. So I can't tell you that this is a papillary carcinoma, right? I can't tell you that this is a follicular neoplasm. I can just tell you that the gene expression profile is abnormal. Again, these patients will require diagnostic lobectomy for definitive diagnosis, and many of these actually still end up being malignant, just without a particular point mutation or fusion. So hopefully that makes sense. You know, if you're looking at this category of you know, a cancer-specific mutation on an FNA, that's very helpful to counsel the patient in the fact of, yes, you have carcinoma, yes, you're going to need surgery. However, you know, if you're looking at a follicular neoplasm mutation, the answer is still, I'm not sure if you have cancer, but you're going to need surgery to help find out, right? So that's why I always look at the findings, because they mean different things for the patient. If we have, yep, 9:44, we have a few minutes. I will explain to you this concept of NIFT-P, since we haven't really talked about it yet. Do you guys have any questions in the meantime?
Nope.
No. Okay. So let's talk briefly about NIFT-P, and then we will be over. So remember our concept of tumors of follicular cells and tumors of C cells. Well-differentiated neoplasms, bad neoplasms, medullaries. Okay, so remember the genetic, yeah, sorry, this is a little bit of a repeat. You remember the genetics, fine. So the TCGA study, which I sort of mentioned before, sorted tumors of follicular cells into those with so-called BRAF V600E-like versus RAS-like genetics. And so on the chart, excuse me, on the chart above, right, it's sort of the tumors on the left, the follicular neoplasms, versus the tumors on the right, the classic papillary carcinomas, okay? So there's true BRAF V600E mutations, and there's BRAF V600E-like genetics that resembles classic PTC. There's RAS mutations and RAS-like genetics that resemble follicular neoplasms. And as I kind of implied before, these are mutually exclusive and essentially non-overlapping in a single thyroid neoplasm. So this is our background, okay? So where is NIFT-P? So NIFT-P is non-invasive follicular thyroid neoplasm with papillary-like nuclear features. This was formerly called a carcinoma. It used to be called the non-invasive encapsulated follicular variant of carcinoma, meaning, what does that look like? The tumor was encapsulated or well circumscribed, right? The tumor grew in follicles. The tumor did not invade adjacent parenchyma. Sounds almost like a follicular adenoma, right? But the only difference was it had nuclei that are normally associated with PTC, enlarged, wrinkled, cleared. So for all other intents and purposes, this is on low power of follicular adenoma, but on high power has nuclei that resemble PTC. So in the past, this was called the follicular variant of PTC. But based on some outcome analysis of these particular lesions, they were found to basically not metastasize, not behave like carcinomas, and therefore the name was changed to a non-malignant diagnosis, i.e. non-invasive follicular thyroid neoplasm, okay? So just, you know, as a reminder of how these sort, we had the former encapsulated follicular variant of papillary thyroid carcinoma. We had the so-called infiltrative follicular variant of carcinoma, which was, as its name suggests, evidently infiltrative and did have a behavior very similar to classic papillary thyroid carcinoma. And we have, of course, follicular adenoma and carcinoma on the right. And so, as I kind of suggested, the only thing differentiating a follicular adenoma from the so-called non-invasive encapsulated follicular variant of PTC was the presence of these regular round nuclei and these irregular wrinkled nuclei. What they sort of look like is shown here, right? So classic papillary thyroid carcinoma with stromal fibrosis and an infiltrative growth pattern. Encapsulated follicular variant of PTC and follicular adenoma, both being very well circumscribed, again, the difference being nuclei, and a true follicular carcinoma having, capsular or vascular invasion. Well, what else do we know? We know that, interestingly, the encapsulated follicular variant of PTC, the follicular adenoma, and the follicular carcinoma all had these RAS mutations or RAS-like genetics, whereas the infiltrative PTCs, whether they were growing in papillae or follicles, had V600E mutations and classic lymphatic invasion, right? So interestingly, the encapsulated follicular variant of PTC was starting to show features more akin to a follicular neoplasm, where there was really only metastasis in the presence of capsular or vascular invasion, which looked very much like follicular carcinoma, and no metastasis in the absence of capsular invasion, which looked very much like a follicular adenoma. So a cleaner line was drawn to separate papillary thyroid carcinoma, non-invasive follicular variant, and papillary thyroid carcinoma, invasive. The name of this was changed to NIFT-P, right? So how I like to characterize NIFT-P is basically very similar to a follicular adenoma, but both genetically and biologically, but being different in the characteristics of the nuclei. Why does this matter? So a former diagnosis of follicular variant of PTC would probably prompt completion thyroidectomy, possibly radioactive iodine treatment. So therefore, if this were a diagnostic lobectomy and follicular variant PTC were diagnosed, the patient had to undergo a second surgery to remove the whole gland, right? The patient had to receive, of course, Synthroid for the rest of their life, with possibly radioactive iodine ablation, depending on the size of the tumor. Now, a diagnosis of NIFT-P does not require any completion thyroidectomy, no Synthroid, of course, no radioactive iodine, just close observation, because these are thought to resemble more closely follicular adenomas that really have low to no risk of metastasis in the absence of capsular invasion. So now we know that NIFT-P is on the sort of left side of this box, right? Where it sorts with the follicular neoplasms very differently from the true papillary carcinomas. So I consider NIFT-P to be essentially a follicular neoplasm where the presence of capsular or vascular invasion is diagnostic of carcinoma. The nuclei themselves are not diagnostic of carcinoma. In the global architectural pattern is also very important. So as a reminder that BRAF like or RAS-like genetics can be very helpful if you're preoperatively dealing with a patient, right? So your BRAF V600E-like genetics will argue for a classic PTC. It will argue against a follicular neoplasm, including a NIFT-P, right? Whereas your presence of your RAS-like genetics will argue for a follicular neoplasm, including NIFT-P, and it will argue against a classic PTC. So this is how I like to conceptualize these lesions in the BRAF-RAS world. Sometimes, if molecular testing has not been done on FNA and there is a not clear diagnosis on the final resection specimen, we sometimes do perform molecular testing on the resection specimens to aid both in diagnosis with this BRAF and RAS-like spectrum. Sometimes in prognosis, if we see something that looks potentially aggressive, we may search for these aggressive types of mutations in order to prompt further treatment for the patient. And certainly for actual targeted therapy, if the patient has a BRAF V600E mutation, they can undergo treatment with BRAF inhibitors. And if they have an NTRK rearrangement, they can undergo treatment with those NTRK inhibitors as well. So various reasons why molecular testing is becoming important for thyroid, both diagnostically, prognostically, and therapeutically. So I hope that was generally informative for you guys. And if you have any questions, I'll take them. Otherwise, I think we are done.